Well, welcome back, everybody, to Ultrasound Grand Rounds. This week, I am really excited to continue on. Last week we did the normal OB ultrasound in the first trimester. We're going to put that on pause for a minute, and we're going to come back to OB. I know I told you we're going to start up a little bit of a series about OB. Definitely going to hit that up later in the spring here. But I have a couple interesting topics to do kind of as we get into March and into April. And today, I'm really excited to have one of my rheumatology colleagues join us in the studio. We got Dr. Cheung C, one of our rheumatologists. He tried to give us a lecture a couple weeks ago. We ran into a little bit of issues, and he graciously decided that he's going to come back because we want to talk to you a little bit about ultrasound for gout. So without further delay, I'm going to switch on over to Dr. Cheung C and let you take it away and talk to us about the treatment of gout and the management of gout using ultrasound. So thanks for being with us today.
Thank you. I have no disclosures. And I'll be showing you a lot of images that I have acquired over the years. Because these were my images, I'm going to apply the Creative Commons license to this content, and you could read about Creative Commons. So I started training in musculoskeletal ultrasound with the Ultrasound School of North American Rheumatologists in 2016. Since that time, I have done over 2,000 studies with over 500 guided injections. Today, I'm going to talk to you about gout. I'm going to discuss the value of the gout calculator in case you don't know about it. I'm going to describe the various ultrasound findings for gout. And I'm going to discuss how not all the patients who can benefit from chronic urate lowering fits in the gout calculator. Here are some basics about gout that I abstracted from a nice review by Niogi in New England Journal of Medicine some years ago. Just because you have a hyperuricemia doesn't mean that you will have gout. Just because you have a normal uric acid doesn't mean that you don't have gout. For those people who have a uric acid greater than 9 milligrams per deciliter, in the next 5 years, about a fifth of them will develop gout. As you know, men are 3 to 4 times more likely than women to have gout. The risks include thiazide, cyclosporin, low-dose aspirin. Genome-wide association studies reveal association with these genes. And as I recall, they are all transporter genes in the kidney tubules, which sort of makes sense. Things that we do that could increase uric acid levels include dietary purines, alcohol, high fructose corn syrup, for example. Just a reminder that both ATP and GTP are also purines. So perhaps that's why there's this common notion that red meat can stir up gout. Dietary items that reduces uric acid levels include dietary milk, coffee, vitamin C, losartan, and phenylfibrate. Here's the gout calculator. I would encourage you to access the gout calculator through this link at the bottom here. But I have included the printed version just so I can reveal to you the calculations behind the scene. A few points to notice here. If you've never had an acute episode of joint or bursal inflammation, the gout calculator thinks that you probably should not think about gout, although, at the end of the talk here, you may feel slightly differently. And if you were able to demonstrate the presence of uric crystal from any symptomatic joint at any point, then you pretty much cannot rule out that whatever the problem is facing the patient is gout. As you note here, this is the pattern of joint involvement. Anything above the ankle basically is neutral in terms of the gout calculator. It doesn't reduce the probability, but it certainly does not add to the probability. And of course, the king is the MTP. As you see, you get 2 points for that. Here are characteristics of the acute attack, and you can basically just read off the list and ask the patient the episode. What are the characteristics? If they have those characteristics, you can just put it into the calculator. Gout is an episodic problem, starts quickly, goes away in 10 to 14 days, and in between time, it should be asymptomatic. So you can, again, ask the patient about those things and then tabulate the result. If you can see skin nodules, and you may question whether that is a tophus. And here's a description of the details of the what constitutes a tophus. But in the Gout calculator online, there's actually a camera icon over here. So if you click on it, it will pop up this picture. So these are really nice pictures of tophus. So you can see the whitish stuff that's showing through the skin that is often thinned and has some dilated capillaries on it. You can see this elbow, for example, has a little white dot, and the ear tophus has a little white dot on it. So that's what we mean by a tophus. Of course, the higher your uric acid level, the more likely you are going to score for gout. But note this thing. Even if your uric acid level is in sort of the normal range, 6 to 8, you still get some points. Even when it's lower than that, 4 to 6, you just get 0 points. You don't get subtracted. You don't get points subtracted from the calculation unless your uric acid is less than 4. So in a sense, you can say if a patient's uric acid is consistently less than 4, you really will have to have a lot of information to say somebody has gout before you go there. This next item refers to whether an aspiration was done and whether uric acid crystal was found. As we talked about before, once you found uric acid in a joint aspirate, gout is pretty much always in the picture, and you really can't rule that out. But on the other hand, if you tap somebody whose joint was ever symptomatic and you actually don't find uric crystal, you take some points away, -2. Okay? And then, of course, the most germane point for this talk is really the imaging evidence for gout. And of course, ultrasound is part of that. And here's the classical double contour sign. So this is the knee. On the right side is the suprapatellar transverse view. You're looking down on the femoral groove. So the bottom white line is the femur. The black area is the cartilage. And then you see this nice white line on top of that, and that's the double contour sign. And on this patient, you actually see it also on the long view over the femoral condyle. I can tell you, this image is over the top. I have never seen something that good, but it illustrates the point. Here's a patient who could probably be an advertisement for the use of Krystexxa or pegloticase, uricase, to treat her gout. She was about to have this finger amputated by the surgeon and decided to come see me. And as you can see, there's 3 more fingers that are waiting for the same fate. So to me, the only way that I can dramatically change that is to chew that uric acid away, and that involves uricase infusion. So here are the ultrasound evidence for gout. The top panel is a double contour sign. So it's the presence of a hyperechoic line that parallels the contour of the bone that overlies the cartilage. And it's to be distinguished from the interface sign. The interface sign is present when there's a thin layer of fluid above a cartilage. And because of that interface creates an artificial reflector of ultrasound beams and therefore creating a white line. The key thing about the interface sign is that it's really strongest when the sound beam is hitting the interface at 90 degrees. As you see here, the contour here is going away from the sound beam, so it's like 135 degrees, but yet it's still present. So this is a strong double contour sign and not an interface sign. Tophus is another thing that we can see on ultrasound, obviously. But here I have to quibble with this definition. It's a circumscribed, inhomogeneous, hyperechoic, and or hypoechoic aggregation. In other words, it could be anything. So there's nothing particularly specific about it. Although in this example here, you see that this joint, what looks to be a metatarsal joint, has a double contour sign in it. So, but that's double contour sign, and that's tophus. You can also have so-called aggregates. And here, these are heterogeneous hyperechoic collections that we think are uric acid crystals that bounce sound beams back quite strongly, so they're hyperechoic. That even if we lower the intensity of the ultrasound, it may still persist as strongly as the bone, and that would be considered a hyperechoic aggregate. I actually jumped the gun a little, but here's an erosion, for example. So you can see that the joint is here, and then just proximal to the joint, there's this bite taken out of the bone, so that's an erosion. And going back to the hyperechoic uric aggregate, I did not find this particular image that good, so here are some other images I've taken from the literature that to me are a little bit more convincing, and I'll have some to show you. But this one, which is labeled tophi, to me looks really good for hyperechoic uric aggregate. In fact, in school, they were telling us that they should look like clump of wet sugar. Doesn't this look like clump of wet sugar to you? So where can we find these ultrasound findings? So here's a study that went through a bunch of patients with gout, as well a bunch of patients with rheumatoid, ankylosing spondylitis, or normals, and then did a very structured exam of a large number of joints. And here's the result. Double contour sign was seen in 61% of the gout patient in the first MTP, and about 40% in the femoral condyles. Hyperechoic aggregates was also found quite commonly around the first MTP, and second on the list was radiocarpal joint. As far as tendons are concerned, patella is the king, triceps is next. And in fact, in their study, if you see changes in the patella and triceps tendon, and you screen both sides, there's 98% specificity. However, the sensitivity was low. Now, if on top of that you add on the radiocarpal joint, the first MTP, the ankle, the talar cartilage, and then either the second MCP or the femoral condyle, you increase the sensitivity to 95%. So in essence, if you look at first MTP, ankle, knee, elbow, and wrist, you would and find things or not find things, then you could have a specificity of over 90 some odd percent and a sensitivity over 95%. In my case, I mostly look at first MTP and the knee, and I occasionally look at ankles. So I'm not quite 95% sensitive, but I think in my case, most of my patients are there to rule in gout, not to rule out gout. So I think I'm okay with that. So here's some cases that I'll show you. To start off with, this is the case that was done in the ED. You guys did it. He came in with a swollen knee, and you guys did the ultrasound and showed a big effusion, and it was tapped, and it showed uric crystal. What was not commented on, I don't think, was this line here that intrigued me. So when he came to see us for follow-up and his joint was better, I still went ahead and looked. So this is a so-called suprapatellar maximum flexion suprapatellar transverse. So we're just bend the knee to get the patella out of the way, and you lay the probe down just above the patella into the femoral groove. So you see the femur here, and you see the cartilage, and you see this guy's, the double contour was really fairly weak, and it's only on the lateral side. Incidentally, the U.S. sonar convention is that medial, proximal, and anterior is on the left side of the screen. So all our images look the same, whether it's right knee, left knee. So anyway, so here's a questionable double contour sign. So I did it on the longwise over the lateral femoral condyle, and now you see a pretty decent double contour sign. In fact, I would submit that this might be the same part that you guys looked at in the ED. In this case, this sort of beaded appearance of that double contour sign is felt by the experts to be a really good double contour sign. Here's a patient in her 80s without a history of podagra, but had previous history of ankle pain and a knee aspirate once that didn't show any crystals. She saw the PCP for an open wound of her finger, as you can see here, with white stuff. So she was sent over to our clinic. By the time she came to our clinic, the wound has healed, but still you can see some. Here you can see the little bit of the white stuff that's a little bit more apparent when we put pressure on it. The ultrasound over those finger nodules were really fairly nondescript, But the main thing is it's not hypoechoic, so it doesn't look like a cyst that I could just stick a needle in there. But when you look back on it, it probably does fit a so-called uric aggregate. However, when we look at her knee, the transverse view shows a little bit better of a double contour than the guy that I just showed you. And on the long view, it shows a pretty nice double contour. And obviously, she has tophaceous gout, so this is sort of embellishing. But nonetheless, these are the ultrasound findings. Here's a patient who has diabetic neuropathy, who had a prior toe amputation. He has had history of olecranon bursitis and history of white stuff coming out of his digits, as well as high uric acid. He has not been compliant with allopurinol. So he was sent to us with acute olecranon swelling. And at the time, he actually had the swelling extending down the arm. So this is an ultrasound of the big toe. So this is dorsal long view, showing what appears to be a double contour. This is plantar transverse. So this is the sesamoids, medial and lateral. and this is a double contour. This is plantar long view of the toe, so you can see the double contour over here. And his elbow shows a little effusion. This is the anterior long over the radial side, and you can see this line, which I'm calling a double contour, that I can even see on the anterior transverse of the elbow. This line here that I'm calling double contour. His olecranon swelling is a what looks to me like a pretty decent uric aggregate that, as you see, as I reduce the gain on the ultrasound, you can still see some of the dots sort of fulfilling the idea that this is urate aggregate. Yeah. So I think with that, I'll end.
All right. Well, thank you so much for that very comprehensive discussion about gout. I thought it was really helpful just to kind of see some pictures and see some cases where we're talking about, what is gout? I know it's one of those things for us in the ED is, is always on the differential for acute joint pain. And it's the thing we want to go to because I think it's probably the easiest thing for us to treat, at least in the ED. But it's always that kind of that scratch your head, like, how do I deal with this? How do I figure this one out? So that was really good. I really enjoyed that summary at the beginning, not only of the clinical gout, but also the 4 signs, the double contour. I wrote them down: the double contour sign, the tophus, the aggregates, and the bony erosions. And so I think if we kind of maybe take one take-home point, that's probably what we want to take is those 4 things, that define the sonographic characteristics of gout. So with that being said, we're going to open up for some questions here, although I had a question that I wanted to sneak in there first. And it's basically this. Every time we talk about ultrasound, we talk about here's a finding. And we like to think that this is a very binary thing. But a lot of times an ultrasound finding represents maybe a differential diagnosis or just kind of a direction that we need to start shifting our thinking. And so in that context, is this whole idea of double contour sign, like pathognomonic in gout? Or when I have a patient with a hot joint and then I see this double contour sign, should that be getting me thinking down, a narrower list of things, maybe gout among them, or kind of how should I use this in the acute setting, as I'm scanning my patients here?
Yeah, so double contour is challenging because there's the mimicker is the interface sign. But interface sign is supposed to depend on the angle of insonation. So in other words, if you change the angle of the sound beam, the interface sign would move with the sound beam so that it's always sort of most bright perpendicular to the way the sound beam is coming in. And on most of our machines, we can steer the sound beam somewhat, and which is why I have those images with the steering turned on. So that's technically what you're supposed to use. But I think the other thing is the movement. To me, if you could gently move, and then that echogenic sign, you can convince yourself is moving along with the bone. See, the interface sign should not move with the bone because it's the interface. The interface, sort of like water in a glass. You tilt it, the water level stays. Independent of how you tilt the glass. So that's how I sort of think about it. But that's a challenge. And we're always so a lumpy double contour sign is supposed to be good. And I think one of the cases I showed, if you look back, had a fairly lumpy looking line above the joint. So that's a good one. And then if it does not stay put when you move the joint, but actually move with the bone, then that's supposed to be a good double contour.
Great. Are there any other questions that we have or that you guys have about POCUS in gout specifically out there in the audience?
Clear as mud.
I think so. I think you comprehensively answered all of it here for us. We got a message in the chat. Nice job. Thank you very much. That's from Diane. So thanks, Diane. All right, so I think we're going to wrap it up here today. Thank you again for joining us for Ultrasound Grand Rounds today. Hopefully this was helpful for you guys. I know it certainly is a topic that's decently new to me. I've done a scant amount of reading about gout or POCUS for gout, but certainly haven't done a ton of it. And so I really appreciated seeing a lot of examples and kind of the utility of how you use the ultrasound to see and to think about rheumatologic conditions. So definitely something that we'll have to circle back and kind of think about some more. But anyway, we are going to wrap things up here today. If you haven't yet gone to our YouTube channel, definitely head on over there, hit the subscribe button, hit that notification bell. All these videos we post up on the YouTube channel so that they can be seen by as many people as possible, so we can get the material out that we're showing, but also something that we can go back and review if there's something that we wanted to refresh ourselves on. So anyway, head on over to the YouTube channel there. As for the plan for future weeks, we are going to be having a spring break coming up here pretty soon. So keep an eye on your email. We'll be sending out some announcements about kind of when we are going to have rounds and not. But next week, I'm pretty excited. We are going to do something a little bit different. I know my co-host is eager to get on here, but we are going to have Diane Gramer, one of the people who's taught me most of what I know about bedside ultrasound, is going to come on the forum, and we're going to talk about Diane's tips and tricks. So all the little things that you don't necessarily read in textbooks, you don't necessarily pick up on on some of these podcasts and some of these videos, but Diane's going to talk about all the things that she's learned over the years, the little things that she teaches us at the bedside to take our ultrasound from this level to this level and make it so much better. So I'm really excited to have Diane on. We're going to talk about stuff. Hopefully we're going to scan things if I can get the logistics figured out. So you'll definitely want to come back next week, same time, same Zoom link to get Diane's tips and tricks. So with that being said, we'll have a good week, guys, and we will see you next time.